Physiology of plasma cells. Normally plasma cells are polyclonal, hence they can produce any among IgA-IgM, both kappa or lambda. Pathology in plasma cell disorders. PCs become monoclonal and produce only one immunoglobulin, MC Ig greater than IgA, Ig kappa. Markers for monoclonal plasma cells. CD19, CD38+, CD138+, CD45. Plasma cells disorders or aka dyscrasias or dysproteinemia, or paraproteinemia. Types of plasma cells disorders. 1. Multiple myeloma. 2. Waldenstrom macroglobulinemia. 3. Amyloidosis. 4. Heavy chain disease. Criteria for a monoclonal gammopathies to be called MGUS, SMM, or M. MGUS, M protein less than 3 grams per deciliter. Bone marrow plasma cells less than 10%. Myeloma defining events, absent. SMM protein greater than _3 grams per deciliter. Bone marrow PC greater than _10%. MDE, absent. MMM protein greater than _3 grams. Bone marrow PC greater than _10%. MDE, present. MGUS and SMM, stands for monoclonal gammopathy of underdetermined significance. Smoldering myeloma, multiple myeloma. What are myeloma defining events? MDE. SLIMCRAB. 60% plasma cells in marrow. Light chain ratio greater than 100. MRE plus VE greater than 1 lesion. Calcium greater than 11 mg per deciliter. Renal failure, creatinine greater than 2. Anemia, HB less than 10. Bone lytic lesion greater than _1. Multiple myeloma pathophysiology. Is a hematological malignancy, arising from monoclonal plasma cells. They produce a immunoglobulin. Marrow has greater than 10% plasma cells, M protein greater than _3 and 1 or more MDE present. Investigations for multiple myeloma. 1. SPEP, serum protein electrophoresis. 2. SIEP, serum immunoelectrophoresis. 3. SFLC, serum free light chain assay. SPEP, SIEP, SFLE, their interpretation. SPEP tells apt difference proteins in serum. SIEP tells about IgM with kappa lambda. SFLE tells apt KPPA ratio lambda. Most sensitive. Bone marrow finding for multiple myeloma. Myeloma cells Russell body or Dutcher body is seen. Appearance of myeloma cell. Large oval cell with eccentric nuclei. Clock face chromatin, dense basophilic cytoplasm, paranuclear halo containing Golgi. Classification for checking the risk in multiple myeloma. M-SMART-3 classification. Divide into high risk and standard risk. High risk multiple myeloma. 17p deletion, T14, 16, T14, 20, T4, 14, P53 mutation, gain 1q, beta-2 microglobulin. Standard risk on multiple myeloma. All other than high risk. Serum parameters in multiple myeloma. Increased calcium, BUN, creatinine, uric acid, beta-2 microglobulin. Pathogenesis in multiple myeloma. Normal B lymphocytes due to genetic abnormalities progress to MGUS, then further to MM. What factors drive progression from MGUS to MM? ROS mutation, CMYC mutation, IL-6 high. Clinical features of multiple myeloma. Bone pain, back pain, lytic lesions, anemia plus high ESR, A-G ratio reversal, recurrent infections, acute kidney injury, cord compression symptoms, neuromyeloma. APL levels in M. Normal ALP cause no new bone formation, only osteoclast activity so hypercalcemia. Why recurrent infections in M? Cause of overall hypogammaglobulinemia, pneumonia, UTI. Acute kidney injury in M. 1. Overflow proteinuria. 2. Light chain cast nephropathy. 3. Light chain deposition disease. 4. Proximal renal tubular acidosis. Most common renal manifestation and most common cause of acute kidney injury in M. Manifestation: light chain cast nephropathy. Cause: hypercalcemia. Neuromyeloma features: psychiatric overtones due to hypercalcemia, headache, tinnitus due to hyperviscosity, carpal tunnel in males due to amyloid deposition. Poor prognostic factors for multiple myeloma. Lambda or free light chains. IgA, IgD, IgE myeloma. High beta-2 microglobulin, high plasma cell in circulation, low serum albumin, high LDH. Drugs for treatment of standard risk patient in multiple myeloma: bortezomib, lenalidomide, dexamethasone. Drugs for treatment of high-risk patient in multiple myeloma: carfilzomib, lenalidomide, dexamethasone. Which drug is given to patients of unfit for transplant or relapse cases? Daratumumab, anti-CD38. Waldenstrom macroglobulinemia aka lymphoplasmacytic lymphoma. Pathogenesis of Waldenstrom macroglobulinemia. Memory B cell undergo MYD88 mutation and CXCR4 mutation and convert into lymphoplasmacytic cells. These cells secrete IgM and it goes into peripheral circulation and in bone marrow. Markers of lymphoplasmacytic cells: CD19, 20, 35, 38. Surface IgM. Features of IgM in peripheral circulation: 1. Cold agglutination, autoimmune hemolytic anemia, cause IgM is big molecule. 2. Hyperviscosity, headache, tinnitus, dizziness, epistaxis. 3. Neuropathy. 4. Raynaud-like symptoms. Features of IgM into bone marrow, in Waldenstrom macroglobulinemia: anemia, pancytopenia, weight loss. Criteria of diagnosis of Waldenstrom macroglobulinemia: 1. IgM monoclonal gammopathy of any concentration. 2. Small lymphocytic infiltration of bone marrow. 3. Markers: surface IgM, CD5, 19, 20, 22, 25, 27, 7 positive. CD10, 23, 103, 138 negative. Serum protein electrophoresis finding in Waldenstrom macroglobulinemia. M-band IgM. Management of Waldenstrom macroglobulinemia: 1. Plasmapheresis PLEX. 2. BR regimen, bendamustine, rituximab. POEM syndrome and major criteria in this: P. polyneuropathy, O. organomegaly, E. edema, endocrinopathy, hypogonadism, protein, S. skin changes, sclerotic bone lesion. Pathogenesis and associations of POEM syndrome: high VEGF, associated with Castleman syndrome. Types of heavy chain diseases of plasma cell disorder: alpha chain disease MC, gamma chain disease, mu chain disease, alpha chain disease aka Seligman disease, and IPSID, immunoproliferative small intestinal disorder. Alpha chain disease features: familial Mediterranean lymphoma, gamma chain disease aka Franklin disease. Gamma chain disease features: autoimmune, patellal edema. Mu chain disease features: Ka, vacuoles in lymphocytes. Primary AL amyloidosis aka light chain disease. Primary AL amyloidosis pathogenesis: soluble precursor proteins due to misfolding conformation change converts to insoluble amyloid protein. Features of this insoluble amyloid protein: extracellular, non-branching, indefinite length, 10 mm width, bright Congo red positive. What's the soluble precursor and type of amyloid protein in primary amyloidosis? Precursor, light chain, type AL. What's the soluble precursor and type of amyloid protein in secondary amyloidosis? Precursor, serum amyloid A. Type, A. What's the soluble precursor and type of amyloid protein in dialysis-associated amyloidosis? Precursor a beta-2 microglobulin. Type a beta-2M. What's the soluble precursor and type of amyloid protein in senile system-associated amyloidosis and FAP-associated? Precursor, transthyretin. Type ATTR. What's the soluble precursor and type of amyloid protein in Alzheimer's disease? Precursor amyloid beta protein. Type A-beta. What's the soluble precursor and type of amyloid protein in cerebral amyloid angiopathy? Precursor cystatin C. Type A-CYs. What's the soluble precursor and type of amyloid protein in medullary carcinoma of thyroid? Precursor calcitonin. Type A-cal. What's the soluble precursor and type of amyloid protein in atrial fibrillation? Precursor atrial natriuretic efficator. Type AANF. Secondary amyloidosis is associated with what disease? Chronic inflammation (TB), rheumatoid arthritis, bronchiectasis. Investigation for primary AL amyloidosis. 1. Biopsy. 2. Immunohistochemistry. 3. Serum protein electrophoresis normal. 4. Serum immunoelectrophoresis high lambda proliferation. Biopsy tissue for primary AL amyloidosis is taken from abdominal pad of fat, rectum. Clinical presentation of primary AL amyloidosis, organs involved. 1. Heart. 2. Kidney. 3. Liver. 4. ANS manifestation. 5. Carpal tunnel in male. 6. Sensory motor axonal neuropathy. 7. Chronic inflammatory demyelinating polyneuropathy. 8. Hemorrhagic manifestation. Clinical presentation of primary AL amyloidosis in kidney. In secondary amyloidosis, nephrotic range proteinuria without nephrotic syndrome. Clinical presentation of primary AL amyloidosis in liver. Hepatomegaly with increased ALP, biopsy contraindicated because of risk of bleeding. Clinical presentation of primary AL amyloidosis in heart. Restrictive cardiomyopathy, MC, low voltage complex on ECG, hypertrophy on echo, sudden cardiac death. Clinical presentation of primary AL amyloidosis in ANS. Nocturnal diarrhea, gustatory sweating, postural hypotension, reflex tachycardia. Clinical presentation of primary AL amyloidosis in hemorrhagic manifestation. Macroglossia, waxy eyelid and papules, shoulder pad, amyloid nails. Prognostic factors for primary AL amyloidosis. High concentration of these show poor prognosis. 1. High serum NT-proBNP. 2. TROP-T. 3. DFLC. Management of primary AL amyloidosis. High-dose IV melphalan plus dexamethasone, autologous transplant.